Right now, our next speaker is Dr. Cheng-Yu from Department of Oncology, TVGH. He will be delivered a talk on immunotherapy for cancer, an emerging therapeutic strategy reshaping the landscape of personalized cancer treatment. Now please welcome Dr. Tang.
Good morning. Next. It's my great honor to talk about the cancer immunotherapy here. So my specialty is in systemic treatment of gastrointestinal cancer, including the esophageal, gastric, biliary tract, pancreas, and colon cancer. And especially, I am involved in the clinical research and clinical trials, including chemotherapy, target therapy, immunotherapy, and especially recently in cell therapy. Before, I want to talk about the cancer treatment evolution because the immunotherapy came out in recent 100 years. For the thousands of years, the surgery remains the only one treatment options for cancer patients. And around the time of the World War II, the chemotherapy came out, and 40 years later, the target therapy became into the clinical practice. And in recent 10 years, the checkpoint inhibitor, one of the most important drugs in solid tumors, came out. The immunotherapy is the concept that a healthy immune system will survey and patrol the whole body and to kill the malignant cells, because malignant cell is regarded as a foreign body. So the healthy immune system will kill the tumor cell. But the tumor cell may express some mechanism to avoid from the immune killing. So the concept of immune killing is come out for many years, but the concept become well accepted as a cancer hallmark around 2011 because the first drug, immune checkpoints, come into approved by the FDA. Here is the timeline of the cancer immunotherapy. I want to mention about several important time points in the cancer immunotherapy. The first one is the cholecystocin. It is the Dr. William B. Coley. He observed that some patient with the sarcoma will have tumor regression after the severe infection. So he tried to inject Streptococcus pyogenes toxin into his patients, and he did observe some tumor regression after the severe infection. For the next 40 years, he treated 1,000 patients with sarcoma with the cholecystocin. It is a mixture of the Streptococcus pyogenes and the Serratia massicans. However, after 1960, because this toxin is being intensely criticized and no longer be used in clinical practice, but we believe the toxin might be the pioneer of the cytokine therapy. The next one is the BCG vaccine. We all know that the BCG vaccine is used as a tuberculosis vaccine for many years, especially in infants. But around the time of 1974, the BCG vaccine is used in non-muscle invasive bladder cancer because the intravesical injection of the BCG can induce a local inflammation in the bladder and to enhance the adaptive and the innate immunity to fight the tumor cells and prevent the bladder cancer recurrence. Until recently, the development of the CAR-T, or we call the chimeric antigen receptor T-cell therapy, has been very, very successful. On the top left is the first pediatric patient received the CAR-T. She had acute lymphoblastic leukemia and had no standard treatment. She received the CAR-T therapy and has been disease-free status for over 10 years. And the case was published in the New England Journal of Medicine. On the right, explain how patient receive the CAR T therapy. The T cell will need to be harvested from the patient first, and the T cell will be genetically modified in the lab. And after expansion, the T cell will be infused back into the patient, and the patient will receive the lymphodepletion chemotherapy to modify their microenvironment to let the T cell be expansion, proliferation, and kill the tumor cells. So it is why the CAR called chimerism, because in the middle is the structure of the CAR, and on the right is the B cell receptor, B cell antibody, and the left side is the TCR, the T cell receptor. The T cell receptor, yeah. So the extracellular domain of the CAR is derived from the antibody, and the intracellular domain is from the T cell receptor. So it is a chimerism from the B cell and T cell. So we call it chimeric antigen receptor. Here is the timeline of the CAR T therapy, and the most important time point is around 2011, because the first leukemia patient achieved complete remission after CAR T therapy, and it is the second generation of CAR, which is the structure I showed before. And in 2017, the first product, the Chimera, approved by the FDA. And also the Chimera, the T-cell cell, is the only one product that is reimbursed in Taiwan by our national health insurance system. And more importantly, because my specialty is in the solid tumors, and in the last year, the first FDA-approved CAR T therapy product has been FDA approved. It is for the synovial sarcoma, but the product need the patient to be very, very special. The HLA type must be the HLA-A*02 type. And because the tumor-associated antigen is the intracellular antigen called the MAGE-A4, so the product needs the patient to be the HLA-A*02 type. However, the CAR T therapy is very difficult in solid tumors because there are many challenges. First one is the solid tumor is very heterogeneous, and the antigen, tumor-associated antigen that we want to target by the CAR T may be lost after the treatment. And also, the physical barriers of the solid tumors may limit the CAR T cell to be trafficking and infiltrate into the tumor core. And the CAR T therapy may complicate with the cytokine release syndrome and the neurotoxicity that limit the patient to receive the treatment. And in the last, the immunosuppressive tumor microenvironment, including the macrophage, fibroblast, neutrophil, and the Treg, may limit the efficacy of these immune cells. And the tumor may express some signals that cause these immune cells to be exhaustion. So on the next one, I want to introduce about the immune checkpoint. In the middle is the T cell, and we can see some cells will interact with the T cell. For example, the dendritic cell, the tumor cell, the macrophage. And the interaction we call the immune checkpoint. This immune checkpoint will let the tumor cells to tell the immune cell, do not eat me. So the scientists invest some inhibitors to block this pathway. Especially the most well-known and the most successful one is the PD-1. It's the PD-1, PD-L1 pathway and the CTLA-4 pathway and the LAG-3 pathway. Here I show the timeline of the immune checkpoint inhibitor, or I can call it ICI. On the right, you can see there are two scientists. The first one is the James P. Allison discovered the CTLA-4, and the next one is the Japanese called Tasuku Honjo. He discovered the PD-1. These two scientists discovered the immune checkpoint and was awarded the Nobel Prize in Physiology or Medicine in 2018. You can see the ICI is very important in solid tumors because it got nearly all solid tumor cancer type indications all over the world, all over the body, especially for the MSI high or the high tumor mutation burden solid tumor, we can use the pembrolizumab. And there are 3 types of the ICI on the left side. The one type is for the block the CTLA4, and one block the LAG3, and the other is block the PD-1, PD-L1 pathway. So here I show some examples of ICI in solid tumors. On the left is the melanoma. We can see the down line is the chemotherapy, and the above line is the immunotherapy. The immunotherapy have a very superior outcome compared to chemotherapy alone. And in head and neck cancer, traditionally we use chemo-target therapy, but if we combine chemotherapy with the ICI, we can have a good response. And in renal cell carcinoma, for many years, we only have one drug called sunitinib. But after the development of ICI, we combine the nivolumab and the ipilimumab, we can have a very good outcome compared to target therapy alone. Especially the response of the ICI may lead to the long-term durable response. On the left, you can see the chemo responder only have 6 months of duration of response. But if a patient responds to immunotherapy, they can get a very, very durable response. And on the head and neck and the renal cell carcinoma, we also see the same phenomenon. So here I show the real-world efficacy of immunotherapy in Taiwan. Here is a report in 2000, and you can see the response rate was around 20% to 40%, and there are 1,600 patients in this report. So we can expect that the immunotherapy may be working in the real world. Here is the data from Taipei General Hospital from 2016 to 2024. You can see in these years, the use of the ICI is increasing rapidly. In the last year, there are 1,700 patients receive ICI, and there are 10,000 person times in Taipei General Hospital using the ICI. Also, we use ICI in clinical trials. In Taiwan, we have a group called the Taiwan Cooperative Oncology Group. It is from the National Health Research Institute. We will perform some investigator-initiated trials in Taiwan to see the efficacy of some regimens. And there are 3 ongoing trials in Taiwan, and 2 of them are led by our medical oncologist. The first one is the Professor Cheng-Yu, and the other one is the Dr. Zhang Nanlong. And one of the trials is for neuroendocrine carcinoma, and the other one is for gastric cancer. Why is the clinical trial is very important? Because we can test some chemoimmunotherapy regimens in Taiwan. The first one I want to talk about is the T1219 study. It is a phase 2 single-arm study. We use the chemotherapy, gemcitabine and TS1, and another immune checkpoint inhibitor, nivolumab, as a first-line treatment in patients with advanced BTC. And you can see the response rate was around 22%, and progression-free survival was 9 months, and overall survival 18 months, and 19 months. And especially, we performed the translational studies in this study. We used the NGS and identify like the alteration of the chromatin remodeling genes or the tumor mutation burden can be a biomarker to identify the immune responder. Also, we performed the IHC and the digital spatial profiling studies, and see that if we stain the tumor tissue with the LAG3, the more LAG3 expression the patient will more respond to the immunotherapy. Also, we collaborate with other medical centers in Taiwan. This study called the Alpha study is another single-arm phase 2 study using anti-PD-1 called pembrolizumab and another target therapy called avatinib in platinum-refractory recurrent or metastatic head and neck cancer. And the response rate is very outstanding. It's around 40%. In addition, we collaborate with many international groups to conduct the international clinical trials. Here I list some clinical trials using the ICI in Taiwan. And these trials are also still recruiting patients. Another main focus of our department is the head and neck cancer. So we also have many clinical trials using ICI in head and neck cancers. And most of them are in the first-line setting. In addition to the ICI, because ICI is well developed and in all the cancer type, the next wave of immunotherapy will be the T-cell engager. It is a modified target therapy with immune modulatory effect. You can see in the left side, the target therapy have different target sites. One can target the tumor cell, and the others can target the immune cell. So this T-cell engager can be a bridge between the tumor cell and the immune cell, and let the immune cell get close to the tumor cell to kill by direct contact. And then on the right down, you can see there are many targets that can be used in clinical setting. For example, the HER2 in the breast cancer, the EGFR in the lung cancer or head and neck cancer, or the CD19 and the CD20 in the B-cell malignancy. And more importantly, the T-cell engagers are approved in solid tumors since 2022. The first one is for the uveal melanoma, and the next one is the tarlatamab for the small cell lung cancer. And this drug, tarlatamab, is already available in Taipei Veteran General Hospital. So some of our patients with small cell carcinoma, small cell lung cancer or the neuroendocrine carcinoma can be treated by the tarlatamab. And on the right side, you can see the tarlatamab will target the DLL3, which is a cell surface marker of the small cell lung cancer cell. And the other side can target the T cell CD3. So this drug can bridge between the T cell and the small cell lung cancer cell. So in brief, immunotherapy, including the ICI, cell therapy, and T-cell engager, has revolutionized the cancer care, and we see the responder may have a durable responder, even cure after the long-term treatment. But not every patient will respond to the immunotherapy. So we conduct some translational studies to find the biomarker and to find a different combinational approach. For example, the chemoimmunotherapy, the target immunotherapy, or the radioimmunotherapy to find the best approach to these patients and to give the personalized immunotherapy to our patients. And thank you for your attention.